Hello, everyone, and thank you for joining us. FUS Partners is pleased to sponsor this webinar in concert with Theraclion. FUS Partners is a program of the Focused Ultrasound Foundation, and it serves as a galvanizing force in facilitating the rapid acceleration and commercialization of focused ultrasound technology. Before we get started, a few technical items. If your connection is lost, please simply log in again using your registration link. At the conclusion of today's webinar, you will receive a link to the recording. I would like to now introduce David Camartin. He has been the CEO at Theraclion since 2014. Mr. Camartin previously occupied the position of Vice President of Mergers and Acquisition Strategy at Alstom Thermal Power and Global Head of Mammography at GE Healthcare. He will now introduce our speakers. Following the presentations, all of the speakers and additional panelists will join us for a live Q&A. Please submit your questions using the Q&A function at the bottom of your screen. And now I'll turn it over to David.
Thank you, Susan. Good afternoon and good morning, everyone. It's a pleasure to explain to you what Theraclion has developed over the last 15 years as evolving surgery model using high-intensity focused ultrasound as a source of non-invasive treatment solution. Our disruptive platform is aimed at combining physics, biology, and merge it with intelligent data to be able to address thyroid nodules, breast tumors, and more recently, varicose veins. Our business is positioned in the south suburbs of Paris in France. We have 25 people, and we're located in three countries, France, Germany, and Hong Kong. We wanted to have a wonderful panel discussion here with three of our top key opinion leaders dealing with varicose veins from UK, from Spain, and also with the introduction of Dr. Elias, who is one of the sound vascular surgeons dealing with varicose veins. Before I introduce you to our speakers, I wanted to talk to you about our vision of evolving surgery, where we want to offer our users additional therapeutic tools to go above and beyond the limitations of their current practice. Because high-intensity focused ultrasound is so safe and so accurate, we can actually mitigate perioperative structures and reduce patient burden. Our intelligent and learning capabilities is meant to continually improve subsequent procedures, and we want to be able to upgrade each and every surgeon therapeutic arsenal with new possibilities. Our solution is meant to create a new environment without scalp spills, without scars and stress. And Theraclion is now shaping a new world where surgery can be completely extracorporeal. To illustrate the purpose of what we're doing, it's our pleasure to have Dr. Stephen Elias from New Jersey, from Englewood Center, who leads the vein center in that facility. Dr. Elias is a vascular surgeon. He's one of the key leaders in North America, but also internationally for venous diseases. After Dr. Elias' presentation about the disease of chronic venous infelicity, we're going to have Professor Mark Whiteley, which is our first commercial user since 2019 dealing with varicose veins, but who has been one of the pioneers of venous ablation with varicose veins more than 20 years ago. Mark Whiteley has 3 clinics, one in London, one next to Heathrow, and one in Bristol. And he's currently treating in the one in Guildford next to Heathrow. And the last of our users is Dr. Ruben Caraval, who is based in Marbella in south of Spain. Dr. Caraval has been using our device since a couple of months. He's one of the most recent experience, and we thought it was valuable to have a mix of different experience. And of course, we have our Chief Medical Officer and VP of Veins, Dr. Michel Nutin, who's been one of the founder, pioneer, dealing with endovenous ablation with venous more than 10 years ago, and who is instrumental for Theraclion guiding us from oncology to a cardiovascular disease. Thank you so much for being here, and it's now my pleasure to introduce you to Stephen Elias.
Okay, thank you. I will share my screen here. Hopefully we'll be able to do this here, share. Yes, you can see it. And then I'll ask the usual question. Can you see my screen? Somebody, yes or no?
Yes, it looks great.
Okay, very good. Okay, so my job, first of all, it's really great to be. I didn't even know there was an organization, so I'm thrilled there is an organization on focused ultrasound. But my job really is to try and educate you a little bit about vein disease. Many of you don't deal with vein disease, and hopefully at the end you'll get an understanding as to why vein disease really should be treated, and why giving the intro as to why Sonovane technology really may be the better step. So what is vein disease? Why treat it? And can we do any better than we're doing right now? For some of you, this may be simplistic, but for those of you who don't know anything about veins, I kind of took the approach that I was asked to give you a big overview. What do veins do and how do they work? Well, veins really return the blood back to the heart. The arteries bring the blood down to all the organs with oxygen, and then the veins return the blood back to the heart. And the way they do that really in general is by the calf muscle pump. So when we walk, our muscles pump the blood back up the legs towards the heart. In all veins, it's certainly in veins, all the veins in the legs, which is the great majority of veins that we do treat, there are one-way valves, like a check valve, that only allows the blood, or a one-way door, that only allows the blood to go back up towards the heart and not leak back down. So it's really a very simple concept. You have a one-way valve that's supposed to just direct the blood back up towards the heart. Here's what in a schematic on the left side, you can see blood's going up. Here are these one-way valves on the side of the vein. And as gravity wants to make the blood go back down, these valves come together so the blood cannot leak back down. However, if the valves get either weak or damaged, then blood can go in both directions. And that's when patients begin to have symptoms in their legs. These are normal veins on the right side, showing that the blood is just going up. And as blood begins to leak back down, as one or two valves become abnormal, slowly, in a simplistic way, that pressure over time will damage further valves lower down, and patients will develop veins that are not working right and may see these obvious veins on the surface of their skin. So what can go wrong again with veins? It's pretty simple. Either they can leak, as I just described to you, in the wrong direction. They can become somewhat clogged, or they can become narrow. So when the blood pools in the lower leg or collects in the lower leg, the valves are leaking. Instead of everything going up, it's going back down. If somebody has a blood clot that kind of clogs those veins from going back to the heart, again, the blood will pool. It's like a blocked pipe in your house. It's blocked somewhere and things back up into the sink or into the toilet or whatever. And then the last thing, you can have veins that are narrowed either by scar tissue from previous blood clots, or narrowed because the arteries that are on top of the veins, mostly arteries in the pelvic area, are squeezing the veins shut a little bit. So again, everything here you see, either leakage, clogging, or narrowing, prevents the blood from going back up the leg. Now, HIFU does not treat the narrowed pipe necessarily or the clogged pipe, but it does treat the veins that are leaking. And that is the great majority of the problem that we see in patients. So as we said, the main issue is the leak, and HIFU is directed at these veins that are leaking to prevent them from leaking again, usually by sealing them shut so that they don't leak. And we're going to get into more of that as Dr. Whiteley, I'm sure, is going to talk about the technique itself. So veins leak. All right, what's the big deal? Here's what patients come and complain of. The acronym HASTI, H-A-S-T-I, is what we tend to use. It's heaviness, aching, swelling, throbbing, or itching. And clearly people say this is worse at the end of the day, because in the morning they've been sleeping, their leg has been up, and even if they have veins that are not working correctly, instead of that blood going leaking back down, their legs have been up, and gravity has helped to drain any extra blood overnight from the legs. So people wake up and say, oh my God, I feel great. But as the day goes on, I want to put my legs up. They feel heavy, they're tired, I get itching over the veins. In general, patients also say walking helps them because, as I said to you, the way the blood gets back is with the calf muscle pump. So if someone says to us, you know, when I walk, I get this pain, in general, that is not a vein problem. And some patients can have complications such as damage to the skin, breakdown in the skin for ulcers, bleeding of the veins, and some inflammation such as phlebitis or blood clots. So what do we see on exam? We see these bulging varicose veins in the leg. We may see some swelling of the leg as well. As things get worse, we may see some pigmentation, again, down at the lower third of the leg, down by the ankle region, because that's where gravity is putting the most amount of pressure, and the skin's reaction to the extra pressure, again, simply put, is to get a little thicker and a little darker to hold that pressure in. And then there reaches a point where it may not hold that pressure in, and people develop ulcers. So that's what we kind of see on exam. Give us some idea. These are varicose veins, these bulging veins in the calf and the lower thigh or on the front of the shin. So this is what we see visually. We may see the pigmentation down in the ankle area as the disease progresses and patients' skin reacts to the high pressure in the leakage of the veins. And then some people may develop open wounds that cannot heal. And you can see the varicose veins leading down to these wounds. So, you know, what's the big deal? Is this like only a few people in the world have this problem, or is it a common problem? And it's very common. In general, 40% of women and 20% of men have some type of vein disease. And as we get older, it gets worse and more prevalent because clearly the veins have had pressure on them over the years. And in general, things, you know, in our bodies don't work as well as we get older as when we're getting younger. And as our population ages, the amount of people who have vein disease continues to increase. In general, though, as opposed to some of the other diseases that maybe high intensity focused ultrasound treats, death or limb loss is not really the main issue with patients with vein disease. Yes, some people can die if a clot in their legs travels to their heart or lungs, but that's not the great majority of people. The great majority of people with vein problems, it's a quality of life issue. They want to feel better so they can get back to their life, rather than having their symptoms on a daily basis that prevents them from doing what they want to do. So conceptually, while it's not saving somebody's leg or somebody's life, it's making their life much better. And there's a huge amount of data that shows that treating veins do make their lives much, much better. So do we need to fix vein disease? Well, no, we don't. 99% of the time, we really don't need to fix it. So why are we talking about this? And why do we need Sonovane? The reason is that as I want you to really understand, it's a quality of life issue. And by doing the right thing and fixing the abnormal veins, patients have a much improved quality of life. And isn't that what it's all about? You want to get back to your life and live your life pain-free, throbbing-free, aching-free, or whatever, so you can do what you want to do. So when we see patients with vein disease, we really look at it not from the disease point, how extensive is the disease. We look at it as how does the patient feel the disease is affecting them. So you need to change your perspective. Many diseases, most diseases in medicine, we treat because we know if you don't treat it, something bad is going to happen down the line. In vein disease in general, that's not true. So we really work very hard to think about the patient's quality of life and keep that in mind when we talk about Sonovane, because even the treatment should not affect their quality of life as much as other treatments. And I think you'll find that Sonovane really is a nice technique to treat these patients who really want to feel better. So again, we got to see how badly it affects these patients. Some patients, especially with those with ulcers or wounds, they're just really not happy. And if you could improve their quality of life, they are going to be thrilled. So how do we improve their quality of life? The great majority we see have a leak. They don't have significant blocked veins or narrowed veins. So the run of the mill, we see 100 patients, 80% or so, unless you have a skewed vein practice that just sees wounds or something, 80% of people with vein disease really have a leak. So there's a huge volume of patients, a population to treat with Sonovane, because this Sonovane addresses the leak. And in general, the techniques we have available now do have very good success rates, but I'll give you an idea as to what they involve in terms of the patient's experience as compared to Sonovane. In 2021, you don't all have to be familiar with all this stuff, but basically just take away that we have 17 different choices in how to treat the leak. And almost all of these in 2021 involve a couple little needle sticks. Some involve putting some medicine underneath the skin before you treat the veins. So the experience of the patient, while better than what we were doing 20 or 30 years ago, which involved making cuts and pulling veins out, while it is better what we have, they still involve some type of invasive technology, albeit it is minimally invasive. And again, as David Comartin said, Sonovane is completely extracorporeal, does not involve any incisions or any invasion into the patient. So what are the advantages here? No incisions, office space. It's extremely precise because, as you all know, you can focus the ultrasound in the area that you want to treat. Easily repeatable, which is important in vein disease and many of the other diseases that the HIFU is treating, in that vein disease is an incurable disease, not incurable like cancer, like people die from it, but incurable in the sense that we don't have a pill to give to somebody, say, we're going to take care of your veins once, and now you'll never have a problem again. So it's nice to have something that's easily repeatable when necessary in the future of the patient that doesn't, again, involve another invasive procedure. And the recovery time is really minimal. So HIFU, I do think it's an opportunity to add more balance to modern vein care and really bring it to the next level, which is completely non-invasive. If you want to hear more about venous disease in general, and actually in our last Venous Edge, it's an online video magazine, the vodcast, we talk about superficial vein disease and we talk about the emerging technologies, so you can access that as well. So I hope I kind of set the stage for the next topic. Thank you all.
Share my experience of using the high intensity focused ultrasound technique for closing varicose veins using the Theraclion Sonovane machine. The background of treating varicose veins really changed in the late 1990s with the introduction of radiofrequency and laser ablation of varicose veins under tumescence. By 2011, people were trying to move away from the idea of using tumescence and heat and started using MOCA, which is mechanical chemical ablation, and then glue. And we're also using foam sclerotherapy by itself, which had very poor results in big truncal veins. However, a really big change occurred in 2019 with the introduction of the non-invasive high-intensity Sonovane machine, which uses high-intensity focused ultrasound to target the veins that are refluxing in the leg. The principles of endovenous thermal ablation are to pass a catheter, which is going to provide the heat energy into the vein, usually in the great venous vein. This is from below the knee up to the groin, and then injecting tumescent fluid around the vein, which closes the vein down by squashing it against the fiber, giving the best thermal contact, providing a heat sink to stop any heat leaking to the surrounding tissues, and of course providing local anesthetic. However, it turns out that the most painful part of the procedure is actually the injection of the tumescent anesthesia. The principles of endovenous thermal ablation are sound, and we've found that even after 15 years in our own experience, there's no groin recurrences at all from neovascularization, which is a common problem and a common cause of recurrence after open surgery. So there does seem to be a huge advantage of endovenous thermal ablation, not only being minimally invasive, but also in reducing recurrences due to this common problem. Indeed, the international guidelines in America since 2011, the UK since 2013, and Europe since 2015 have put endovenous thermal ablation as the preferred treatment for varicose veins of truncal origin. The principles of all endovenous ablative techniques is to cause transmural death of the vein wall. Before this, it was thought that if you close the inner aspect of the vein wall, the inner lining, which is the endothelial cells on the intima, then you might somehow stick the vein together. However, this is shown to be erroneous, and the only way that you get permanent closure of the vein, as suggested by myself in 2004, is to kill all of the cells across the vein wall. This is shown diagrammatically here in a book I recently wrote called The Leg Ulcer Treatment Revolution, where a vein on the left-hand side here, if we follow the top line, we show damage only to the intima and endothelium, which causes the blood inside the vein to clot, causing thrombosis. And this in the short term looks like the vein is closed, only to recanalize and reopen and come back again in the future. This is why we don't trust reports that show a relatively good result in the short term, but by 1 and 2 and 3 years show a reducing success rate. If, following the bottom line, we have transmural death of the whole vein wall, we end up with fibrosis and complete involution of the vein, and it disappears within about a year or so. This is a permanent closure of the incompetent vein and is what we're aiming for. So where does this fit in with high intensity focused ultrasound? Well, using echotherapy and the sonovein machine by Theraclion, we can now achieve this endovenous thermal ablation type pattern, but extracorporeally, using this from outside of the body. The sonovein machine has 2 ultrasound systems working in synergy to produce the results it does. The first is a grayscale ultrasound imaging, so we can see the target vein and aim the machine. The second is the dome, which focuses the ultrasound to a set focal length point to give the beam of high intensity focused ultrasound and the target point, which we will discuss later. On the left here we see a cartoon showing the 2-dimensional grayscale ultrasound, and on the right we see the great saphenous vein with a little bit of local anesthetic around it, which is gives a black halo around the vein. The target vein is the grey dot in the middle of that black halo in the middle of the screen. When the high intensity focused ultrasound is fired from the dome, a successful treatment is noted by seeing this white cross in the middle of the scan we see on the right hand side. And this is reflection from bubbles that are being formed in the ablated tissue, and on either side the black holes on each side of that shows that there's no reflection back from the surrounding tissue, which in this case is a lot of local anesthetic. Immediately post-treatment, we can see the bubbles that have been caused by the thermal reaction in the great saphenous vein and the surrounding local anesthetic, which is degassed before we inject it, which has had no reaction at all to the ultrasound treatment. In this short video, we can see treatment of a small saphenous vein using the old 8-second pulse in the original sonovein machine. You can see at this moment we're aiming the machine and just selecting exactly what I'm going to do. Treatment. You can see the blue bar at the bottom showing a cooling from the previous pulse.
That comes, say stop straight away if you feel anything. How's that feel?
So using that initial 8-second pulse, we performed a zone of ablation at about 90 degrees centigrade, something like 5 millimeters in height and 3.5 to 3.6 millimeters across. But as you can see, it not only took 8 seconds to fire, but it also took about 40 seconds to cool between shots. On the original machine, there was also a 4-second mode, so obviously half the time, with a bit of a quicker cooling time, which caused a narrower sort of ablation zone, and this is particularly useful for small veins such as perforators. Although HIFU is extracorporeal, the fact that the high-intensity focused ultrasound goes across the vein shows that we still get the transmural depth that we need, because it ablates across the vein wall from the outside to the outside on the other side and through the middle of the vein, so we don't need the endovenous device to get transmural depth of the vein wall. So to go back to our slide of the progression of how varicose vein treatments have changed over recent years, we got to 2019 with the introduction of the sonovein machine by Theraclion that you've already just seen, but now in 2020 they produced a much faster version called the Sonovein S. The thermal effect of the Sonovane S is the same. It's 5 millimeters by about 3.5 millimeters across and about 90 degrees centigrade, which is enough to ablate the tissue. But look at the timings. Firstly, the new treatment time is only ½ a second per pulse, and the cooling time is 8 seconds, meaning that we can fire this 5 or 6 times a minute when we're getting into our stride. This is completely different from the original machine. So our early experience of the Sonovane S, which we started in October 2020, has shown that it's much quicker. We're able to treat much longer sections of veins because it is quicker. 50% of our patients have not required any local anaesthetic at all, and because there's no anatomical disturbance by any local anaesthetic, it's easier to see the vein and to aim the machine. I'm now just going to demonstrate this on a treatment of a right great saphenous vein that we performed on the 9th of December last year. Once we've marked the course of the vein on the skin using ultrasound, we then hold the leg firm by using this special cushion and taking all of the air out of it, which holds the leg in position so it can't be moved during treatment. Then move the head of the Sonovane machine into position.
Great saphenous vein there, straight away. Going into the junction there. Because we've marked it on the surface, you can go exactly down here.
Some patients don't need their hands, so don't worry, some do.
So we can see the vein here in the middle. Okay, so now we have the great saphenous vein here. We're going to go to the positioning. We're going to lock this. We have to put the laser into range here. So the laser onto the machine there, laser set, bring the skin down, and now we're more or less where we're going to start here, but what I'm going to do first, I'm just going to come up to here. There's the junction I want at that point there. Bring the vein right into there. So there's the great saphenous vein. We can go to the longitudinal view. There we are. And in longitudinal view we can see the vein here. It's coming out. Just a little bit of rearrangement of that. And there we are. I like to see the longitudinal section of the great saphenous vein. So here we can see the great saphenous vein here. Doing now. Okay, so we've got the great saphenous vein here. We're right on it. We know where we are longitudinally. We're going to look here. The skin is in the right place there. We can just go up a little bit to check the great saphenous vein higher up. And we can see how it's good starting to drop down there through the sphenofemoral junction. And we can come all the way down the great saphenous vein here. Comes up there, and it's on the muscle at that point, so almost definitely we'll need a little bit of local anaesthetic for this one, but you can see it's all in one place, so as long as the patient stays still, we'll be in the right place. Okay, that's lovely. So just going to, that's at the junction there.
So in this case, we're just putting a little bit of local anaesthetic around the vein to try and lift the vein off the muscle. This is to separate the great saphenous vein away from the underlying muscle. If it wasn't for the fact it was lying on the muscle, we'd be able to do this without any local anaesthetic at all. Most patients can't feel the local anaesthetic going in because it's placed underneath the cool balloon, and with the pressure of the balloon and also the coolness of the cooling fluid on the skin, it actually has an anaesthetic type effect.
Leave the skin crease up here a bit more. There we are. So we can now do 300. And just here, a little bit. And and we're just going to go under the vein a little bit there. There we are. And so we can see there's a vein just there. And you can see, I'm just going to put a little bit of pressure on. I'm just going to try and see if we can squash the vein a little bit. Just to try and keep the...
She was the star. Yeah. So I decided to do more. 2.5 now.
Beautiful. So if you just from there to there, you can see how it's the vein before and after, before and after. So once you've actually completed those centimetres, we now mark where it is on the leg. We then go back to here, do end treatment, new segment for the current position, yes. And then holding this exactly the same, and watching the vein that you've got marked already. Push the little button on the head. The robot arm resets itself. And you're set to go straight from the same place again. But now you've got a whole thing. You lock the laser in place. You make sure the lens skin is in the right place there. And there we are, we're on the vein now, and we're ready to go again.
So these photographs show the end of the treatment of the great saphenous vein, and in this case we treated almost 20 centimeters of great saphenous vein. This patient also had incompetent perforators, and this is the technique I used to close the incompetent perforator. We placed the sonovein directly over the perforator that has been marked with ultrasound before the case began. Using the aiming tool on the ultrasound, we can then position the target directly on the perforator right at the fascial cross. The treatment is then fired, which is half a second for the pulse, and we repeat this several times for a perforator, somewhere between 6 and 12 times on average. And this is what we expect to see. We can see the bubbles formed in the ablated tissue in the perforator right at the fascial cross.
Yeah, it's a tiny bit.
Just a tiny bit. Not too bad?
No.
Not bad enough for you to sack Carol?
No, not at all. Not
No.
here. No.
I can't suck any of it back out. No, this is... So basically, the position we've got to now, how long have we been operating? 10 minutes, 15 minutes?
Started at 5 to, it's 5 past, 10 minutes.
10 minutes, right. So where normally where we'd be now, with the old technique, would probably have been about 40 minutes. So that's why I'm so in love with this technique.
Initially, when we started sonovein for the truncal veins or perforators, we performed immediate foam sclerotherapy afterwards for any varicosities and tributaries. However, the patients saw no advantage because they had to wear the compression for the sclerotherapy. So we now perform sonovein to the truncal veins or perforators as needed to get rid of the reflux, leave usually about 8 weeks, and then see do we need to have any foam sclerotherapy at all, or has the sonovein closure of the veins been sufficient in itself to correct the problem. We have submitted our 1-year results of the sonovein treatment for the AVLS this year in October, and I'll also be presenting them at the VEITH Symposium in November. So in conclusion, using high-intensity focused ultrasound with the Theraclion machine sonovein, and particularly sonovein S, this is truly a non-invasive treatment for varicose veins. And our early results, without giving the game away too much, but what we've shown is it's certainly as effective as the early results from endovenous thermal ablation were back in the early 2000s. We often combine it with foam sclerotherapy for surface veins, really depending on what the ultrasound shows after treatment and what the patients wanted 8 weeks afterwards, and of course what their aim is. There's a difference between someone trying to cure a leg ulcer from someone trying to have a more cosmetically pleasing look to their legs. The sonovein S is at least 6 times faster than the previous sonovein, and half the patients that we treat don't need any local anaesthetic at all, which not only speeds up the treatment but makes it less tender and also makes it a much more satisfying treatment for patients as they get onto the table, have the treatment, and then walk straight home again. And we don't even use any compression stockings post-treatment nowadays. We are now collecting all of the data on the HIFU treatments that we're doing at the College of Phlebology Venous Registry. And this will help us monitor results not only in our own unit, but also in people taking up the Sonovane treatments. Thank you very much for your attention.
So Steve, thank you for that comprehensive summary to help us understand the etiology and medical effects of venous disease. And Mark, thank you for explaining the details of the Sonovane technology. I'd like everyone to put on their camera so we can start the live Q&A portion. And I'm excited.
Okay, good. I got it. Sorry.
Yep. And I'm excited because I have lots of questions for everyone. We've just heard from physicians in the US and the UK. So Dr. Carvajal, I would appreciate it if you would be kind enough to share your experience from Spain now.
Okay, thank you, Susan. So first of all, thanks to the FUS Foundation and Theraclion for the kind invitation to be here today. Where in Spain, I have started with therapy a few months ago, as David Comerton told you before. But we have a major experience with Professor Luis Izquierdo that starts last year with the therapy too. So we are close to 50 patients right now with a really good results and even a really good patient experience related with the therapy. Basically because they are in a no OR situation. So they know that they will have no scars, no incisions, and overall they immediately leave after the procedure to come back to its normal life. So that's the key points for patients, and they are really answer really well for the proposal of the therapy. And for me, it's a really important key point that offers this therapy. Overall, to put all the therapy outside of the operative theater. Equally, there is not needed for any anticoagulant therapy after the treatment. And as Mark says, it could be done even without anesthesia or with a little amount of anesthesia in key positions. In our experience, we have even 2 patients fully sleeping during the treatment in the room, just creating a quiet environment with the music and with lights. So that means that I mean the therapy is absolutely well tolerated for different kind of patients. And that's all I want to say. If you want to do some questions, would be nice to answer it.
Sure. Thank you for sharing that. I actually have follow-up questions for you and for Mark. And can you talk a little bit about the patient inclusion criteria? Can you treat anyone with venous disease, or is it just mild, moderate, or do you have to exclude patients with severe disease, or how do you determine which patients are candidates for this procedure?
Shall I answer that first? So at the moment, it's actually not so much the patient severity, because it's more the vein you're treating. So you can treat either people who've just got thread veins, but when you scan them, they've got underlying perforators or truncal reflux causing the thread veins. That would be the most minor sort of varicose veins. They're suitable for this because you have to stop the reflux underneath all the way through to venous leg ulcers. So it's all about the patient inclusion criteria. It's nothing to do with the severity of the disease, but it's the morphology of the veins. What we have to do at the moment with this, we have to think about how much can we close within the time period that a patient will accept. So you're really looking for a patient with a single truncal vein or 2 shorter truncal veins, or maybe 5 or 6 perforators and a little bit of truncal vein. So it's more about the time of the procedure. However, I think that's going to change dramatically as the technology improves. Theraclion are putting so much effort into the technology to make it faster, to make the identification of the vein faster, and that's really what doctors want. They don't, they want to have treatments that are easy for the patient to walk straight in, no need for an operating room, jump straight up on the thing, no pre-meds, not even get undressed, have the treatment, and then walk straight home without a compression stocking, which is quite possible with this sort of technology.
Susan, if I may, I have also a question for Mark. Mark, you are the one who has performed the first venous radiofrequency cases in the UK more than 20 years ago. I have had the pleasure to be part of this adventure with you back then. And since you have introduced a lot of new methods or techniques in your country, and now you are the first to perform HIFU on veins in the UK and the second one worldwide. So let's say that with your experience of serial early adopter, where would you place Sonovein as a panorama of various methods, and which are the perspective of it in your opinion? And just a subsidiary question, which may annoy the participants, which are all three eminent vascular surgeons. In your opinion, is this method reserved for surgeons or it is feasible by other specialists?
Very controversial questions. So I'll answer the first one, which won't get me shot too quickly. When we introduced radiofrequency, at that time, there were no other endovenous surgeries around it. So we were competing against stripping the veins, which was general anesthetic, very painful. We introduced endovenous surgery. At first, everyone thought we were mad because, you know, what burning veins, it sounded ridiculous. And I must say, it was a real struggle at first. When we started doing it, it was still general anesthetic. We were still binding the legs with rubber, but we sort of held with it because we knew that eventually it would come good. And of course, now people, 20 years later, people walk in, have an endovenous laser, it's much quicker, local anesthetic, walk in, walk out. So the technology has, although it's the same basic heating, the technology of endovenous surgery has made it the great technique it's been. This is the same seed change again. And this is, I've written a paper on this in the current medical opinion and research thing, saying, I believe this is the next disruptive technology, because I think the next thing is get rid of the OR, get rid of anything invasive. We are right at the beginning again. Well, probably not at the beginning. We were with the old machine, the 8-second machine. We're already taking a massive step to go to Sonovein S. And we're seeing that same progression. And I think we're seeing the same step from open surgery to endovenous surgery, now from endovenous surgery to completely extracorporeal surgery. And I think when we look back in 5, 10, 15 years, we're going to really look at this and say, this is a significant increase, a significant change as the first endovenous was. When it comes to who should do it, in my own personal experience, I mean, the reality is whoever does the ultrasound, because this is something that you need to be incredibly good at ultrasound diagnosis. So if a vascular surgeon or radiologist or interventional radiologist or even vascular technologist is very good at ultrasound, then they're going to be very good at Sonovein. What you do need is you need to have the understanding of venous pathophysiology. So you do need to have an exceptionally good understanding of venous disease. And I think the difficulty, the same way that at the moment endovenous surgery can be performed by a surgeon who learns radiological techniques or a radiologist who learns surgical techniques, that nobody is born to be the right person. The thing with this is there are lots of hybrid bits that you need: a good ultrasound, good understanding of veins, good patient selection, all those things, and talking to the patient. And of course, what will become really important in the future is also insurance. You know, we talk to do it, but I think on a practical level, you know, this will be able to be done by the technologist, overseen by a doctor who's checking it.
Great. Thank you for that comprehensive answer. There are a lot of really important things to consider. Michelle, maybe you could address when the first patient, we have a question from the audience too, about when Theraclion and this device could be used in the US for the first clinical trial.
Yes, thank you, Susan. First of all, I am impressed by the tremendous interest generated by our robotic and artificial intelligence compatible technology in the US. We are literally receiving every day requests from all over the place, from Anchorage, Alaska, until Key Largo, Florida. And I was impressed, but not amazed, because the US have always been at the forefront of early adoption for the new vein treatment methods, with a much higher percentage when compared to Europe of endovenous catheter-based methods, which are the novelty thing which were the novelty thing 25 years ago. So extracorporeal HIFU veins treatment clearly rang a bell in the States. Concerning our first steps in the US, we are in the starting blocks for the FDA submission, which will allow us to have the first cases performed, hopefully, by the end of this year. We are sitting on solid ground with a much more sophisticated and consistent offer in terms of energy delivery and workflow following the CE mark approval of the Sonovein, as mentioned by Mark, the second generation of our system. And we are now rapidly approaching 1,000 treated veins in patients on top of the plethoric preclinical and ex vivo experience. So this gives us a lot of confidence in what we will be proposed for approval for the FDA. And by the way, we are not naive. We know very well that we have to be present in the US, which is the most influential territory in vein treatments, as soon as possible and with the best possible material. So hopefully first patient treated on the East Coast before the end of the year.
Oh, that's great to hear. Thank you for giving us that information. Ruben, I'd like to ask you to start off the next question. Mark was talking about who could potentially do this procedure, people who were really good at ultrasound and people who really understood venous disease. Perhaps you could talk a little bit about the learning curve and how long it takes to be able to perform this procedure with confidence, this technology.
Yes, well, the fact is that I think that obviously the knowledge of the physiopathology is a key point, because you have a good skills doing ultrasound and planifying your therapy, then it's going to be easier to understand how the machine, how the new technology could help you to treat your patients. And I think that this is the basis, and that's the real key point. Regarding the useless of the machine, I think that it's not really tricky. It could be a little bit difficult at the beginning to manage with the interface, but for me, it was taking just 2 days with a wonderful team of Theraclion that it's always guiding you and helping in all the technical points, that it's probably the most difficult thing to manage of the machine. But after you are involving your activity with the phlebology field, is not really a big thing, a big issue to be involved in the therapy and to do it in a good fashion.
Thank you. I know with any new technology, especially one that changes something from invasive to non-invasive, there's always a little bit of trepidation. Mark, perhaps you could share your experience on the learning curve and what you've experienced, and some advice for others that may be interested in performing this procedure in the future.
Yes, exactly. I think the it's very interesting, because exactly as Ruben's just said, the first thing you have to get over is the fact that the same with open surgery. You know, 1 minute you're doing something with your hands and you're doing surgery, and we're all happy as surgeons doing that. And the next thing, you're suddenly having to learn that you've got the ultrasound machine up over there, and you're sticking lasers in here, and you're trying to do like a video game. This takes it a stage further. You know, you're not even touching the patient, and you're not even looking at the patient. You know, the patient's on your right, and you're looking at the screen, and all your manipulations on the screen. So it is a complete different change. So there's the first thing, as Ruben was saying, is the understanding and getting used to the machine in front of you. The second thing, and what we learned with endovenous surgery, is back in the good old days of open surgery, we did the operations we did because we based them on the anatomy we could reach by making incisions in skin creases, not necessarily the anatomy we wanted. And once we had endovenous surgery, we suddenly found that if we could hit it with a needle, we could actually do different bits. We could do sections of veins rather than whole vein. We could change our approach, and that's been revolutionary. And that takes a longer time, because that's not a learning curve, that's a discovery curve. Now with extracorporeal, we're going to go through that again. So what we're going to do is we're going to mimic the treatments we do at the moment with endovenous laser radiofrequencies foam with this technique, because that's what we know. But there's two things going to go in parallel. Firstly, there's going to be the understanding of the machine, its capabilities, and how to do that. But also our understanding of venous disease is improving all the time. And I sincerely expect us to change our strategy as well, because we will now have the tools to do so. And so I think there's two learning curves. There's the learning curve of saying, right, let's learn how to use Sonovane, but there's now going to be the learning curve of saying, the group of people, we're now understanding this is actually how you can treat venous disease, which we didn't know before because we didn't have the tools.
Great, great. That was a great recap of how to think about this new technology. So thank you. We have a question from the audience that says, how long does it take you to treat a full saphenous trunk from timetable on to table off?
That really depends upon the size of the vein, compliance, how easy it is to see and everything, and is how much you're going to do a full saphenous vein. So I would, with this technique, I usually close about 20 centimeters, and then there's rarely a need for more than that unless there's a perforator, which I close separately. And I've done that right down to about 25 minutes. If everything goes really, really well, I mean, that's really quite possible. Sometimes, you know, you just lose a vein and it's difficult, or the patient's moving, or it's a big vein. So, you know, with patient selection, I mean, I think you heard on the video there, sometimes we've had people with perforated vein disease, they've got C4, they've got quite nasty disease, not just varicose veins, but skin changes, and they've got 4 or 5 big perforators. They may have had the great saphenous vein treated 5 years before. We know it's just the perforators. And compared to preparing them, putting the laser in and everything like that, this is actually quicker for that sort of one, because it's literally in, hop up, see it, zap it, and each one takes about 2 or 3 minutes. So it's, at the moment, I would say that generally this is still going to take longer for the surgeon, but as in total time of patient in the theatre, it's already getting, in the right patients, it's already getting commercially viable. It's just obviously for very complex patients, it's more difficult, but it certainly isn't, well, like a year and a half ago when I was talking about this, I was saying, you know, you bring your packed lunch and you sit there all day, but you know, it's already moved on in leaps and bounds with this new Sonovane S. Okay, thank you. And talking about the technology and how it's getting better and better, David, I'd like to ask you a question. How is your experience with breast and thyroid focused ultrasound? How is it useful in developing this platform? And how do you see the robotic platform evolving to make it faster and an improved user experience for both the physician and the patient?
Well, thank you, Susan. I think first and foremost, the more than 4,000 cases over breast and thyroid tumors over the world, from the US to Hong Kong and also in Europe, has helped us tremendously to make a very safe treatment. Before and foremost, Theraclion is easy to use, and because it was developed with surgeons all over the world, but our accuracy with the high intensity focus ultrasound is less than 1 millimeter. And that was really, with the experience of Michel and, Alfred Obermeier, and then with Mark, and then all the Ruben of Europe, we're now 7 users on Sonovane. We've been able to very quickly understand how to improve workflow and efficacy, and we'll continue to do that. And that's our commitment. It's a commitment of a board to keep funding innovation and make it faster and more efficient. We've designed Sonovane S, was essentially the only HIFU system in the world who can automatically shift from a 3 or 1 megahertz depending on what the user want, and we keep on playing with that evolution. As Mark mentioned, we are going to bring, with a partnership we have with a French ultrasound player called Supersonic, which is now belonging to Hologic, improve subsequently the imaging capability of our platform. And with this new generator and this new imaging solution, these are basically the 2 pillars for us to be able to significantly invest into artificial intelligence to repeat faster what our users are asking or are doing, on the repetitive task. And when you bring this to the next level, you basically have a non-invasive imaging platform, which can use all the deep learning algorithm to basically make a better treatment, regardless of using of HIFU or sclerotherapy or combined treatments. So really the long-term vision for us is not to be a medtech player, but a health tech player, investing in physics, biology, and artificial intelligence.
Okay, thank you, thank you. And Steve, I want to bring you back into this conversation. How would you if you had the dream scenario and all of a sudden the machine appeared at your office, how would you start to incorporate this into your practice?
Well, hopefully the machine will appear in my office relatively soon. And we will hopefully be giving you more information about the US experience at some point. So no, it's incorporated into the practice exactly as we've all been talking about. First of all, obviously the right patient is the first thing. And then the learning curve, yes, there is a learning curve. And I've got to see Mark do some of these procedures with the older technology. And there's no question there's a learning curve, but I don't think it's all that much as much as we think, people who are used to looking at ultrasound images. So I think people should really keep that in mind and not be dwarfed by the device itself, but focus in on the ultrasound use. That's what everybody's used to already, and you need to have people doing it who know how to treat vein disease already. You're not going to take some neophyte and bring them into this. This is for the person who's already doing it, who understands it well, and then can understand where it fits into the practice. And I think it will fit in for the great majority of patients that we see, because the great majority of them do have veins that are leaking. And so the volume, the amount of people that are going to benefit from this, I think is quite high. So yeah, I see it as really the next thing in the practice that ultimately will probably be the majority of what we use to treat people whose veins are leaking.
Okay, thank you. And I'll present a question out to everyone, whoever wants to answer this one is, when you consult the patients, what do you tell them is the time interval between when they'll start to see improvement in their symptoms? And are there any long-term effects or adverse effects that can happen during the procedure?
So I'll say, I mean, in general, what I tell patients all the time, and we've spoken about this many times, is setting their expectations. And no matter what you do to veins, whether you seal them shut, take care of the leak, whether you unblock the narrowing or whatever, people may see sooner, but in general, I tell them it's going to take 6 weeks and up to a few months to see the full effect. Because as Mark showed you in his the video, he's sealing the leaking saphenous vein shut. But there's a lot of varicose veins connected to that. And they've been stretched for a long time. So it takes time once you take the pressure off of those other veins, because you're not going to treat every single vein, for those to shrink down. So in general, it's not like 2 days later they see a big difference. Some people tell me a week later, oh my God. But in general, tell people 6 weeks minimum, up to 2 to 3 months for any vein procedure. I don't know what everybody else thinks, but that's kind of what I tell them.
The experience we've had for 2.5 years, I totally agree with Steve. I mean, you do get the occasional patient who's maybe got this severe pain every time they stand up because they've got reflux down the great saphenous vein, and they have a miraculous change. As soon as they put their feet down, they feel it. But that's 1 in 100, 1 in 200. Most people, it's the constant ache, the tired legs, and as Steve says, you've got to wait for the hemodynamic effects of closing the vein. As far as complications are concerned, we've actually seen very, very, very few complications. We've had one patient where we were trying it on, and we did a small saphenous vein, and we probably were a little too aggressive, and the patient got what's called a neuropraxia, a bruising of the nerve. It is healing like all neuropraxia is done. It's not a permanent nerve damage, but we see that if you do open surgery or endovenous thermal ablation of the small saphenous vein as well. So we've seen no complications that we would worry about, and certainly none that we wouldn't expect with any other minimally invasive procedure so far.
Okay, well, it's come time to unfortunately end this session. It's been fascinating. I really appreciate all of you for sharing your expertise, and I am thrilled that focused ultrasound has this application that could really help improve the quality of life for people, and it really seems transformative to making this an extracorporeal therapy that's much easier for the patients to enjoy this treatment. So thank you all for sharing your expertise. This concludes today's webinar. If your question was not answered, or if you'd like more information, please visit our website at fusfoundation.org or email us at info@fusfoundation.org. Again, thank you for joining us today, and stay tuned to our newsletter and website for invitations for future webinars and events. So thank you all. Have a great day.